My name is Kush Desai. I'm the Assistant Dean for the Southwest Campus for the Medical College of Georgia, and I'm part of the hub team for the Georgia Colorectal Cancer Control Program. So that we get to know each other, I know many of you already have, but you can enter your information into the chat box on the right. Let's go over today's agenda with you. Next slide, please. So first we start with introductions. Then we have a didactic presentation from an expert presenter from South Carolina, Dr. Schlueter. We'll have some time for Q&A. Then we have a case presentation. It's going to be about Colorectal Cancer Awareness Month, which was March. Then we'll have a little bit more time for Q&A, and then we go into our CME and conclusions. Next slide, please. So Project ECHO stands for Extension for Community Health Outcomes. Our motto is moving knowledge instead of people. Just to let everybody know, we do record sessions. These are for educational purposes. We also catalog these on the iECHO platform. To protect patient privacy, please don't mention any patient health information discussions. Next slide. This is just to let y'all know that we do collect data for quality improvement purposes. Next slide. Just general reminders, please mute your microphone when you're not speaking, and you can unmute yourself when you do speak. We do encourage questions, so please put questions in the chat box or raise your hand, and we'll call on you and we'll be able to get all your questions answered. Next slide, please. So our expert speaker is Dr. Schlueter. He's a family medicine physician and since 2013 has served as the Chief Medical Officer for Cooperative Health, a FQHC serving patients in the Midlands of South Carolina. Dr. Schlueter grew up in a rural town, Yellow Springs, Ohio. He attended college at Brown University, Providence, Rhode Island, and med school at Case Western University in Cleveland, Ohio. He completed a family medicine residency with the University of South Carolina in Columbia, South Carolina. Dr. Schlueter has practiced 23 years as a family medicine physician. He's interested in promoting health in South Carolina, but most importantly, those in rural and underserved communities. As such, he's worked in community health centers for his entire career. As a public community health advocate, Dr. Schlueter believes in maximizing low-cost, high-yield screening activities to include cervical, breast, lung, prostate, and colorectal cancer screening. His presentation will be on caring for the community. So Dr. Schlueter, you can go ahead and take it away.
All right. Well, thank you, everybody. It's always interesting doing a Zoom presentation, but I can visualize seeing all of you in the room in front of me, and we're going to have a fantastic time. Always do when we're talking about colorectal cancer. So why don't we move ahead with the next slide? And for us for today, always have objectives. And so this session will provide guidance of a patient reminder with the utilization of Azara. We'll talk about that in a little bit. Care gaps report to identify and contact patients due for annual wellness visits. We'll review how the Azara pre-visit planning report supported our provider reminder to ensure patient gaps were covered during office visit. And then we'll provide an overview of quality measure outcomes to show the effectiveness of this evidence-based intervention implementation into the clinic workflow. All right, next slide. So a little bit about Cooperative Health. We were founded in 1981 by pediatrician Dr. Stuart Hamilton and his wife, Barbara Hamilton. And our mission, which really has resonated with all of our employees, is to provide accessible, high-quality, compassionate healthcare in the spirit of the Good Samaritan. And so that parable in Luke about the Good Samaritan really has made a difference for us. And one of our my colleagues said, you know, over 43 years, the Good Samaritan message resonates, inspires our employees who daily answer the call to serve their fellow man, treating patients and families with dignity and respect and partnership and as neighbors. Go to the next slide. So we are covering 14 counties, have 17 campuses, 26 medical offices. So in the state of South Carolina, right smack in the middle, we cover the Newberry, Fairfield, Lexington, and Richland County. have about 57,000 patients, 220,000 annual visits, employee base about 600, and we cover most of the basic primary care specialties: pediatrics, internal medicine, family medicine, orthopedics, pharmacy, traditional counseling, psychiatry, obstetrics and gynecology, podiatry, dentistry, and ophthalmology. Next slide. Oop. So for us, one of the things I'm really proud about in terms of cooperative health is our holistic framework of care. A model of care we realized many years ago that the traditional model of care, primary care, provider, nurse, and our front desk operations team members was just not enough. So we began introducing additional members to our care team. We call a patient care coordinator who, just as it says, helps coordinate care and helps meet patients regarding social needs. Then our behavioral health consultant is a behavioral health trained team member who helps provide exam room assistance with any behavioral health needs. And then community health workers who link the office to what's happening in the community where the patient lives. So we call that our model of care. Then we have specialty services to include podiatry, pharmacy, OBGYN, dental, psychiatry, counseling, orthopedics, radiology, vision, laboratory services. Then to round things out, niche community services that have made a big difference in terms of meeting the special needs, going all the way from Ryan White HIV and hepatitis C treatment to a migrant seasonal agricultural worker program, providing virtual or video-based primary care services, mobile unit, homeless and refugee resettlement program services. We talk about health outcomes as really important, using the 3 E's: engagement of the patient, educating the patient, then empowering patients. Enhancing the patient and the family and care team experience is really important to us. And then as a community health center, increasing access to care. That's not just the number of patients that we see, but also the locations of where we have our offices and the hours that we provide care. Then one of the things that we've introduced to our health center is bringing humanity back to healthcare. Healthcare has really been in a state of chaos for everybody. And part of our goal at Cooperative Health is to try and bring that human aspect back to healthcare, whether it's from the patient perspective or our employee perspective. Next slide. So then that goes back to this presentation. We're going to be talking about one of our offices called Little Mountain Pediatrics and Family Practice, which is located in the county of Newberry. So Newberry County, pretty small, rural, 37, almost 38,000 residents. The demographics, 60% white, 31% Black, 8% Hispanic. Poverty rate about 16%. Then going to Little Mountain, it is maybe, a couple stop signs, maybe a stoplight, 369 residents. And at our Little Mountain office, we have 1 pediatrician and 1 adult clinician. At the time of this colorectal cancer intervention, we had an outstanding nurse practitioner who had a doctorate in nurse practitioner, 21 years of experience. And then the support team, 2 MAs, 2 LPNs, and a charge nurse. Then we had a lab technician. Just for background, our electronic health record is Athena. We have a population health data management system called Azara. And then thinking about colorectal cancer, offer local community-based colorectal cancer screening, whether it's local colonoscopy, Cologuard, or the FIT, which we offer through our partnership with the Colorectal Cancer Prevention Network for those who are uninsured. The colonoscopies are completed in Newberry, which is maybe about a 15, 20-minute distance from our Little Mountain office. So next slide. So starting in 2021, Cooperative Health partnered with the Colorectal Cancer Prevention Network on Colorectal Cancer Quality Improvement Project. And this project was going to include all of our adult offices. So there were some important steps in this project, and one was developing a partnership between CCPN and Cooperative Health, setting a goal of increasing the colorectal cancer screening rates on a longitudinal quality improvement project sustainability process, identifying offices, forming office teams, and then all of the office teams participated in a quality improvement boot camp to learn the quality improvement process. And then with the help of the Colorectal Cancer Prevention Network, they work with guiding each office, reviewing each of the quality improvement processes over the first year of this project. So on the right is the quality improvement processes, looking at the area of focus, setting a global aim statement, process mapping, looking at root causes, process mapping again, and then looking for modes for improvement. So that's where we started as an organization and for a Little Mountain office. So next slide. Well, so at the end of the day, the Little Mountain office came together and put together an outstanding quality improvement process. So the why, to increase patient visits of unscreened or underscreened patients, allowing a provider to assess patient needs and recommend colorectal cancer screening in a face-to-face visit. So that was kind of the why. The how, pulling quarterly Azara care gap reports. And again, Azara is our population health data management system to identify patients due for colorectal cancer screening. And in this case, we'll talk about in a second, diabetes. Goal, outcomes, improve our quality measures, and then results using the patient reminder and clinic workflow at time of call to patient for annual visit scheduling is most impactful to significantly optimize colorectal cancer screening and other priority measures. So going to go in a little bit more detail on the next slide. So a lot of arrows and lines in the middle, but it was really a lot of work on the pre-visit side and the post-visit side that I feel like made a tremendous difference for our Little Mountain office to have some success. So the first step that the Little Mountain office did was they conducted a global assessment. Okay, state of the state of colorectal cancer screening at Little Mountain. Reviewed the workflow. So the workflow in process mapping is in front of you. And then we conducted a baseline assessment, developed an Excel roster of patients who either had a FIT test ordered, Cologuard ordered, colonoscopy ordered, and were outstanding. And so using this roster just was able to determine where we were at the start, looking at what screenings were completed, but maybe we didn't get the results to close the loop, or what screenings were not completed, and engaging patients to continue that road to getting screened. So that was a very important starting place for us. Then the next step was active patient recruitment. And so what the team did was using our Azara population health platform, they generated a gaps in care report to come up with patients who were eligible for colorectal cancer screening. To combine that with our chronic disease, they also pulled a gaps in care report to determine which patients had diabetes and an A1C that was greater than 9. So those who were most uncontrolled. So they looked at that roster and combined them together to look for those who had the most uncontrolled diabetes and needed colorectal cancer screening, with the goal of reaching out to those patients to bring them into the office. So we had April, one of our LPN nurses, she started calling patients, a minimum of 2 patients per day who had that gap in care, encouraging them to come into the office for a face-to-face visit. So this was kind of initiating our outreach campaign. Then the next step, we had the team come together and to prepare for the patients coming into the office. So they developed a collection of patient education material related to colorectal cancer screening and other health maintenance screenings that could be used to help with, again, patient education. Then we also knew that there was going to be an element of patients that was going to fall through the gaps, whether it was being insured, but having some barriers, uninsured. And so we researched options for patients who would not necessarily qualify for the usual screening program. So when we engaged them, when they came into the office, we didn't want to then have some barriers that we could not address with them immediately at that time. Then the next step was in-office patient engagement. So that's kind of what happened in the center of this process mapping. So at the beginning of each day, using our population health management platform, we would pull a what we call pre-visit report, or PVP report, to identify patients that not only needed the colorectal cancer screening, but other health maintenance screenings as well. So the team would huddle together first thing in the morning, review the report, and then when the patient actually came in for the office visit, we would provide education on the purpose and benefits of colorectal cancer screening, engage patients by providing education on other health maintenance screenings. Then for patients with uncontrolled diabetes, develop a diabetes action plan, and make sure that we were making sure that the patient's primary concerns were addressed. And sometimes the screening was not the top priority, but we still made sure that the screenings were included. We found that this was working very well. And so initially we had just one of our LPN nurses reaching out to patients using the Gaps in Care report. And once we found this was working really well, then other members of the clinical team were recruited to become part of this patient recruitment process. So that meant making sure that they were fully educated on colorectal cancer screening and such. And then they also were engaged with calling at least 2 patients that had a gap in care report to come into the office, not only for their medical part, but also for the screening part. And so this, we found, increased the traffic of patients coming into the office and gave us an opportunity to address not only the clinical concern, which was keyed on diabetes, but also the screening concern that was there. Then the last big step, which is on the post-visit side, is closing the loop. Having the education wasn't enough, putting the order in wasn't enough, but we really wanted to make sure that there was closing the loop for all of this work that was done. So that meant putting together a spreadsheet and monitoring the colorectal cancer screening and health maintenance measures to make sure that the patients completed the test, and then we got the results back in terms of the results. So this is using this process mapping is what we did at Little Mountain. So go to the next slide. So this was the results. We started at 21% colorectal cancer screening rate. And then as we, as a team met and improved our workflow and our processes, we were able to increase our colorectal cancer screening from, again, 21% into the 40s. What we were most proud of was in 2023, in our data management platform, that is when the colorectal cancer screening recommendation went from age 50 to age 45. But we would normally assume that our screening rates would go down because we increase the volume of patients who were eligible for screening. But we found that we were able to at least flatline initially, but then as we moved into towards the end of 2023, our rates went up a little bit more. So we also found that through the outreach to our patients, that we also increased the traffic to our Little Mountain office by increasing our patient encounters by 33.5% from 2022 to 2023. So go to the next slide. So a little bit of background in terms of the patients and the community that we are serving at our Little Mountain office. So for calendar year 2023, for our screening eligible patients age 45 to 75, we had 2,172 encounters. Of those encounters, about 63% were with women and 37% men. The race breakdown, 54% white, 25% Black, and 20% Hispanic. I do have the Newberry County demographics to that side. And so if you notice, the 8% Hispanic for the county, but for our office, we were at 20%, so much higher on that side. And we also had 18% where Spanish was a primary language. Then in terms of unduplicated patients, again, 45 to 75, about 484 unduplicated patients. And then notice that the ratios of women to men in terms of encounters was about the same, and also with the race breakdown and in terms of Spanish language, which was very interesting. Then also broke down the age 45 to 75 based upon 5-year increments. And, it was very interesting in terms of the distribution that we had. And then we had a separate part of our Azara patient management system that would allow us to calculate out the insurance status for those. And so about 36% were privately insured, 32% uninsured, 25% Medicare, and 7% Medicaid. So we had a much higher uninsured rate. When we look at kind of Newberry County and Little Mountain, the poverty rate, the patients that were uninsured was fairly high. So next slide. Okay, so in terms of colorectal cancer screening, again, the slide that we saw at the prior slide is now the data to the right. And so we had 453 patients based upon our UDS report for colorectal cancer screening, 45 to 75. Again, we were at 43% completed. That meant 57% had that gap in care. And the gap in care is as below, about 63% women, 37% men. And then the race breakdown, 49% white, 28% Black, 24% Hispanic, and 23% Spanish speaking. So the demographics followed almost exactly the just general demographics for the office. And then in terms of those who insurance-wise who were not satisfied for colorectal cancer screening, about 34% were uninsured, and 66% were insured. So this data was very interesting because I might have expected that those who had gaps in care might have been a little bit different, but it really followed the percentage that we had in the general demographics for the office. Next slide. So as mentioned a little bit earlier, we did not just focus on colorectal cancer screening, but when patients did come into the office, we focused on chronic disease as well as other recommended screenings. And we found that through this effort, that not only did we see our colorectal cancer screening rates improve, but we also saw our screening rates improve for things like tobacco, breast cancer, cervical cancer, our blood pressure control rate improved, and then our diabetes percentage of patients that were uncontrolled, improved as well. So this was not the results of just seeing colorectal cancer, but all of our quality measures improved across the board. Next slide. So some reflections of the Chief Medical Officer of this project and doing colorectal cancer quality improvement just organization-wide. Having motivated executive leadership is really important. Also having the tools. So Azara was really important for us, that in just really a few minutes we can be able to get reports on how we are doing. But also noted that it's not just the tools, but quality improvement requires time, preparation, and data to be successful. And then quality improvement workflow. I sometimes am one who hears a project and jumps in the deep end, but doesn't take the time to learn, work, and utilize that 6-step quality improvement process, which is really important. And then a big part of the success at our Little Mountain office is identifying a clinician champion. And so the clinician, Miss Odette, she was outstanding not only in terms of her years of work, but also her leadership. And she was wanting to be a leader of the team and really had a motivation from within or in a higher calling and really viewed quality measures such as colorectal cancer screening an important part of what she is as a clinician, and always maintaining an optimist, cup is half full attitude when it comes to moving patients from a gap in care state to a fulfillment state. We have learned in our education about moving patients through the stages of change. And this is really important in terms of always having a positive attitude when it comes to patients and moving them from a state of having a gap in care to getting them to having that completed. And then identifying office support team champions. This is not just about the clinician, but the support team from the LPNs to medical assistants really have to be on board and identifying some champions to help, make this happen is really important. So next slide. So this is our team on the bottom right. Miss Odette Fisher-Glover is in the middle, and then Rosetta and April, the two LPNs that worked with her on this, flank her. So, success at the Little Mountain Family Practice Office was really about getting patients to their physical visits. We came out of COVID, getting them back into the office, really important. Assessing patients and focusing on priority issues. So not only their health, like diabetes, but also, getting the screenings included and getting patients involved in the screening decisions. It's not just a top-down approach, but really providing them with education and having them understand the why, but also with our clinical teams to have them understand the why as well. Those things are really important. So unfortunately for us, Miss Odette, she became a grandma and decided that was really important for her, and she moved on from the office. But she shared on behalf of the Little Mountain Family Practice team, she would like to thank the team for assisting over her 2 years while she was with us to improve colorectal cancer screening outcomes. Their suggestions and recommendations provide the needed catalyst to drive improved colorectal cancer screening overall. And we consider this a win for our patients and the community. So next slide. All right. So that is it for my presentation. Really, thank you for giving me the opportunity to share a little bit about Cooperative Health and about what we did at our Little Mountain office to improve not only colorectal cancer screening rates, but to improve our other quality measures and improving our access to care, which was really important for us. So that's the end of the presentation.
Thanks, Dr. Schlueter. That was very informative, especially as we're in Georgia doing have similar same grant but similar program and are facing many of the similar issues. So let's see. We have a couple of questions. So Dr. Hotz.
Yes, thank you very much for a very impressive presentation. And I think we've walked down some of the same ground as you guys. One of the things that we are challenged with is doing that focused outreach. Here's your list of patients. They're not coming in regularly, a lot of them. How do you reach them? Because what we find is it varies on the clinic as far as their ability to connect with folks, phone numbers change and that. We also find the motivation of the person making the call is essential. We're selling a product basically, and you need to have a very motivated sales force to get that person in. What have you found as far as ways to overcome that challenge in reaching the folks and also finding a way to motivate that outreach person to basically sell our product?
Well, great question. So as a CMO, I have lots of clinicians that I work with, not just at Little Mountain, but across our organization. And I did have some clinicians that were, I will say, kind of a fatalistic attitude. They're not going to change. They're not interested. And so, I'm just going to kind of do my minimalist. And what I found is that it really comes to that personal attitude, that cup half full, that kind of comes within, makes a tremendous difference. And sometimes that can be um, grown and fostered in people for them to realize that, what they do does make a difference, and not having that fatalistic, attitude. And then trying to find motivation, whether it's through personal experiences as it relates to colorectal cancer, or just these things in general, which provides a why. And so if, our team members have had a family member who had a certain situation, that they could be able to tap into to really get them inspired, can make a tremendous difference. So those are things that are really important. Now for the Little Mountain office, they spent some time networking as a team, developing that why, and then also making sure that the team members were prepared to speak and to answer. And that they had the talking points when they were engaging patients. Now, the other thing that many of us, universally share is phone numbers. Oftentimes, our patients and their phone numbers just don't seem to be accurate, or it changes. So that was always something that we appreciated. But again, we made the effort to make those phone calls. And again, we didn't reach out to patients that were out of care for a year and a half. We tried to reach out to patients who had been in care recently, where that information might be much more correct and up to date, that we might be able to have a successful connection with them.
Thank you.
Thank you. Looks like we also have a question from Dr. Sheldon. Dr. Sheldon?
Yes, I think my mute's unmuted. So thank you for an excellent presentation. And I must admit, I was impressed with, your ambition, not just to address colorectal, but other UDS measures as well. So, kudos for you. I think, so Little Mountain, the one thing question, Little Mountain's like a group of, like a little town of 350 people, but your panel was a couple thousand patients. So you must be drawing in from more than just Little Mountain, I'm guessing.
Yeah, so in Newberry County is a growing county. So I'll just say on the northern end of Little Mountain, we have the city of Newberry, which is, pretty big. But then also on the lower end of Newberry County, there's a growing community called Chapin. And so so we're really drawing patients from Newberry and also from the Chapin community that kind of converge together at our Little Mountain office.
And you have two providers or more? You have a pediatrician and a nurse?
And just an adult clinician.
So, and they bought into this pretty strongly, both of them. I guess not the pediatrician so much, because it's not quite as central.
Sure.
Yeah.
But yeah, so in this case, it all goes back to having as mentioned before, a team that really sees a purpose and is really seen as this as a mission. And so our adult clinician there, Miss Odette Fisher Glover, she really saw this as being important, and personally motivated to lead the team to make this happen.
And can you review that 6-bullet change model that you talked about?
Sure. So the quality improvement process, if it were up to me, I would just, at the very beginning, just jump in and propose solutions. But I learned with the quality improvement process that you have to take some steps. So gathering your team is really important, and understanding each member of the team could have different strengths and different weaknesses, but everybody on the team is important. And then identifying what your topic is. So for us, that is, colorectal cancer. And then the next step is to, understand where you are at. What does the data tell you that you're starting at? And then thinking about, what is your goal? Where do you want to become? Then thinking about your process mapping. What is your current workflow? Not what you think it should be in your head, but what your current workflow is. And then trying to think about what your workflow should be. Then thinking about certain gaps, okay, certain things that will limit you from being successful. And then looking at evidence-based interventions, low-hanging fruit, so we're not trying to sail around the world in 2 days, but small interventions that can make a big difference. I call that low-hanging fruit, low cost, high yield, and then putting those low cost, high yield interventions into practice. And then, assessing after a period of time, did that work? If it worked, great, continue it. If it didn't work, then make a note of that and pivot to something else. So that workflow of going through that quality improvement process is something that I learned as a part of, this colorectal cancer program with CCPN. But going through those steps in a methodical manner can be very important for long-term success.
Okay, thank you. Did a good job with that. Thank you so much.
Thank you. Looks like we'll have time for one more question. We may have time for questions at the end as well, but Dr. Gabram's had her hand up. So Dr. Gabram, if you can.
Yes, again, outstanding presentation. I really enjoyed it. So we have access to a population management system in one of our FQHCs that we're working with, but not the others. How did you go about selecting Avara? And how did you go about paying for it? Because these things are not cheap, but it sounds like that was key for your team to have access to accurate data.
Oh my gosh, you are absolutely right. So I'm old enough to have paper charts where you had to do, pull 75 charts and go through them manually and have a spreadsheet, and looking at complete disaster in terms of time and efficiency. But having our population health, Azara, came about through a partnership with our state primary care association. And so that's kind of how it got kind of funded and facilitated for us. And so that is what really made a difference. So when we started this process, Azara was pretty much already on board. And this colorectal cancer screening was a great opportunity for us to actually use it for something of significance over a longitudinal period of time. And so with Azara, for any of our UDS quality measures, whether it's breast cancer screening, colorectal cancer screening, smoking, diabetes, blood pressure, mammography, et cetera, we were able to, at a touch, really in seconds, see where we are as an entire, organization, be able to look at how a particular office was doing, how a particular clinician was doing, how we did last year, how we are doing up to date, this year. So it really facilitated obtaining the information and allowing our team members to be able to get that information as well. The last thing, though, that was really important is it didn't just give us data, but with the reports, we were able to pull a gaps in care report, which actually showed the unique patients that had a gap in care from their name, medical record number, address, and those types of things. So now we're able to have actionable patient level information that our team members could, again, make those phone calls because they had a list of the actual patients that were available. And then with Azara, it did come with what we call a pre-visit planning report, where you can just, it would look at our appointments that we have for that day for a particular clinician and generate a report that would allow us to huddle in the morning, see what the gaps in care are for any individual patient that day, and being able to move forward. So that made a big difference, not only with colorectal cancer, but the other gaps that might be going along with it, and address them all at the same time. So that made a big difference for us to allow us just to be successful, because otherwise, you know, it would be very difficult.
Great, thank you so much.
Thank you. We can go on to our next section now. Your next slide. And so as a reminder, last month was Colorectal Awareness Month. So we did a lot of different activities around our state to recognize this and to spread awareness of colorectal cancer. So here's just a few examples. So we've had several, we had Dress in Blue Day. We've had several events all over the state of Georgia. We had an interactive session, a webinar run by Georgia Core and Katrina and her team to get some folks more that are from around the state to get them more knowledgeable about colorectal cancer screening. And we did some messaging campaigns, which is text messaging on both on East Georgia and on Southwest Georgia at APHC. So next slide. Here's just some fun pictures from around the state. Next slide. All right, next slide. And so Cynthia Merchant's the CEO of Horizons. They provide navigation for this program, and so she did a special on one of the local news networks. So we'll listen to her.
Well, you might have noticed many are wearing blue today here at WALB and across the nation. That's because today is National Dress in Blue Day to promote Colorectal Cancer Awareness Month. WALB News 10's Madison Foglio shares how one South Georgia Cancer Coalition is getting the word out about early screenings.
Not only is blue a fabulous color, it also raises awareness for colon cancer, a disease that's rising in younger adults across the United States and is easily curable if detected early. And that's where Horizons can help.
Our focus is really on cancer screening navigation. The #1 goal for our organization is to get more people in our community and our region screened for cancer.
A recent study from the American Cancer Society found that for the first time, colon and rectal cancers have become the leading cause of cancer-related deaths in adults under 50. Dr. James Hotz with Albany Area Primary Health Care says one of the reasons for this is a change in lifestyle habits in our younger generation.
We've seen an increase in obesity. We've seen a decrease in physical activity. Smokers, people who drink heavily, all those things go to change what's called the microbiome, which is the bacterial content of the colon. And we think that causes some toxic reaction that has increased the incidence in people under 50.
Dr. Hotz says the best way to lower your chance of dying from colon cancer is by getting screened.
75% of everybody who dies of colon cancer are behind on their screening. To me, it's the madness that we can have effective technology that can reduce the death rates of colon cancer by 80% if we just got people out and got them screened.
Horizons Community Solutions helps uninsured and underinsured individuals across South Georgia navigate the cancer screening process from start to finish.
It's a rural area, so going to the doctor is not just like hopping on a bus and getting a ride over in most of these communities. You've got to have transportation. We knock those barriers down for people.
Horizons Community Solutions is using today and the rest of this month to continue their push for colon cancer awareness. You can find more information about Horizons resources over on our website at WALB.com. Madison Foglio, WALB, your hometown news source.
Very good, thank you. So that was a really nice presentation from both Dr. Hotz and from Cynthia to get the word out there for colon cancer awareness month. We have next slide. And so this is this was our organization also got a grant from Fight CRC on advocacy, and Lynn Durham is the president and CEO of Georgia Core, which actually holds this grant. And so she was out in DC wearing blue and advocating for prevention of colon cancer. Next slide. And so this is some of y'all have seen this, but I know a lot of y'all have not. This is actually one of our patients. He's given us permission to give to publish this, and then hopefully this goes viral. And that's the hope, is that more people see this. But this is an actual patient that was one of ours through this program. He's going to tell y'all a little bit about his experience through this program.
Hey, my name is Sable Fleming, and I am the clinical liaison here at East Georgia Healthcare. Today, I have one of our colorectal cancer patients.
My name is Sean Jordan Pittman, and I go to the doctor here, Miss Lauren Davis.
Mr. Pittman, how did you hear about the colorectal cancer program?
Miss Lauren Davis recommended me I have a colonoscopy and have it done, and then they found a polyp.
And was it easy for you to go through the screening process?
Yes, ma'am.
Okay, how was the navigation part? Was it easy? Did they call you?
They called me, told me exactly what I needed to know and how to do it, and I had no problem going right through with it.
What would you tell your family and friends or neighbors about getting screened for colon cancer?
It's a good thing to have done, because unlike me, I did not know I had it, and thank the Lord that my doctor was mean enough to make me go take it. And I love her for it now, because they found out I had the stage 1 cancer and they got rid of it.
So you had no symptoms prior to your screening? It was just a routine screening?
Just a routine screening. I become that age, and she said I need to go see about getting one done.
So what was your initial reaction when they told you you had colon cancer?
It scared me to the point of just sitting in shock.
Right.
Because I didn't know what to do. All I know is my Dr. Bishop assured me that he would take care of me and he would get rid of it, and he done what he said.
Yep. So within actually a month of you having your colonoscopy where they found the polyp, within a month you were cancer-free because you had a transverse colonectomy.
Yes, ma'am, it sure was.
If it weren't for the grant, do you think you would have been able to get the colonoscopy?
And you know, even if I hadn't got the grant, I would have done everything I could, but I'm thankful by all means that the state of Georgia has this grant for me to get this done. I don't know what I'd have done without them.
Very good. I know a lot of us have seen this several times, but it makes us emotional every time we go through it, because it is really touching and really from the heart. And it really shows impact in a way that our numbers really can't. So it's really nice that we were able to have a patient like that. And I know we have many others, but this is one that we were actually able to record. Next slide, please.
Hey,
Just one last reminder for anybody that's on the call that is from East Georgia or from APHC. We do have a screening competition. We're going to be going around. I'm going to be next month. I'm actually going to be going to all the clinics to spread the word. But we're going to have a screening competition from January for basically the whole year. So January 2024 to December 2024 for the highest screening rate provider and the most improved screening rate as well. And so then winner will be announced at 2024. We'll have some gift cards and some awards by the end. So whoever is the winner will, of course, save a lot of lives, but also will get some really true. Yeah, this is just the webinar we did last slide. Next slide. And do we have any other questions? I think Dr. Patton, you had a question from earlier. This may be a good time to ask, and if there's anybody else that has questions, we have a few minutes if you want to put them in the chat box or ask.
Yeah, so my question goes back to the first presentation. So if there's something that's relevant to what you just covered, I'll sit back for a second. But if not, I'll go ahead.
Sure. If anybody has questions for any of the colorectal awareness or of our survivor or anything else. If not, we can go to Dr. Patton.
Sure. So that was all of this is just great news, and it's so good to see the engagement around the state, and then also to hear the great news from our neighbors up in South Carolina. I'm just amazed at the disproportionate number or percentages of Hispanic patients that were engaged in the screening effort. And when we talk about communication, I think it seemed like over 2/3 of them were identified as having Spanish as their primary language. I didn't see anybody on the team that looked like they might be proficient in Spanish. Maybe they are, but I'm just wondering if there was any special insight into how they were able to communicate so effectively to the Hispanic population to get their engagement up.
Great question. So at Cooperative Health, it wasn't in the picture, but at many of our offices, we do have in-person interpretive services. And then we also offer a video-based language line that is able to provide interpretive services using an iPad in the exam room. So that has made a big difference for us and being able to, address that gap. And, you're rightly noted at our Little Mountain office, the number of Spanish speaking patients was higher than in general for the county. And so it definitely was an area that the office had to address and prepare for. But that's, again, something that as an organization, we do provide that service at all of our offices, whether it's an in-person individual or using a video-based language line.
Thank you.
That's great. Thank you.
Very good. Are there any other last minute questions? Dr. Gabriel?
Yeah, one more question. Have you realized any effect of your text messaging campaign at all? Have we seen an uptick in the clinics, and did you run it like throughout the month, or how did you really go about doing that differently in Colorectal Cancer Awareness Month?
Is that for me in South Carolina? Or just in general? I'm sorry.
Yeah, no, I think we did it in Georgia, but if you also did it in South Carolina, sure. If you want to answer that.
I was going to say we did not do that as part of what we at Little Mountain. What we did was more phone type of engagement, but it'd be great to hear what happened in Georgia for text messaging.
Yeah, we did. Is Sable on the call? Or Robbie? They didn't have the more up-to-date information, but we got some response. Robbie?
Yeah, sorry, no, I'm clicked on the slide, so I had to find out where the mute button was. Yeah, we haven't had any data yet. So I think as of next week we might have some more, just because it just ended with the month. I think we did it mid-month. I think on the 18th or 7th. I forgot which date they actually sent it out, but we do get metrics back. One of the things when we had previously done it, we found that a lot of the numbers, as Dr. Schlueter, you mentioned, that none of the numbers were out of date, or they didn't have minutes, or we couldn't leave voicemails. And so that was one of the main issues of just getting the up-to-date information for the patients, which is continuously a problem. That's why we're working on trying to initiate a trusted contact, not a emergency contact, but a trusted contact. So we were able to reach out to the patient for things like cancer screening, and missed appointments and things like that. And that we're still working on adding a line to the EMR in order to capture that with the front desk. But maybe Sable, I don't know if she's on, but if she is, then if they already have the data, then maybe they can share.
Yeah, I don't think we have data on that side either. We did it and kind of variable response. It wasn't like we had a a huge influx, but I heard there were some people calling in. I don't know, Dr. Sheldon, do you have any insight on the texting campaign?
No, I don't. But I did have a question for the Little Mountain Project, because you mentioned about the low-hanging fruit. What do you think gave you the most bang for the buck, for lack of a better word, in terms of the interventions that you did?
Well, great question. So I think there were, if my math is right, probably three or four things that made a big difference. The first one is being prepared for the patients when they came into the office. There's nothing like just having things out of order and not being prepared. But when they came We had our education materials in place. We had a workflow in place in terms of our pre-visit planning, huddling. So when the patient showed up, we were prepared for them. And so that was really important. I think another low-hanging fruit was when the patient said yes, placing the order, and then doing the best that we can to make sure that the order went to completion. So engaging the patient, making sure that they got the procedure done, and then that we got the result back. So, you know, we know that not everybody is going to be a thumbs up for screening, but if they are thumbs up and they affirm that they want to do it, then engaging the patient to procedure completion, whatever it is, and then getting the result back. So preparing for the patient in the office and, you know, making sure that there is good, you know, once the order is placed, that closing that loop. I think those are two things. And I think the other thing that allowed the office to really start well is that they looked at the orders that were already placed and said, hey, those are patients that already had thumbs up, affirmed it, the order was placed, and why don't we look to make sure, was the order done? Did we get the result back to engage the patient? So, you know, that was a great place to, you know, to start. And then you start getting some successes of, oh, patients got it done, we got the result back. Okay, how can we engage them in the office, get them to yes? And then once that order is placed, closing that loop and making sure that they are, you know, that they're going and getting the result back. So I think that those are, you know, three areas that is low hanging. Each area is a little bit different, but I think those were the most important in terms of low hanging fruit.
Okay, thank you.
Thank you. Next slide. For the conclusion, so Robbie's going to tell everybody, tell you all about CME.
Yep. To claim your CME credits, please follow the link in the chat that'll be posted, that has been posted. Let's see. And then just in closing, thank you all for attending. Thanks, Dr. Desai, for leading us through these presentations and discussions. Thanks, Dr. Schlueter. I'm sorry, how do we say it exactly? Schlueter.
Schlueter,
Okay,
there you
Dr.
go.
Schlueter.
Fantastic.
Perfect. Thank you, Dr. Schlueter, for sharing your wonderful program and everything that you've done. And thank you for all who've offered comments and questions. Moving forward, we'll need volunteers to prevent case studies in the future. So if anyone has a particular case would like to bring up or share with us, please email us at au_CRC screening@augusta.edu. A reminder that the next session is Wednesday the 5th at 4 p.m. or June 5th, sorry, at 4 p.m. And we will share the flyer with information within the next couple weeks. So thanks again for attending, everyone, and we'll see you at the next session. And for the hub team, please stay on.
I think it's just us now.
Yeah, I think this is it. Yeah, the Augusta team is celebrating their public health school right now, so well-deserved break they got.
We had 40 participants, so
yeah, I think it was a good
number.
turnout.
We had good people from all over the state or all over the country, in addition to the state. So
Yeah, I was going to ask Brenda, did you post it on AMP? Is that why you got people from all around the country? I just wondered if you advertised differently.
I share with the contact list that you sent to me.
Okay.
That was because, and I always share in my Twitter account where I share like education information or whatever, and sometimes AU reposts or Georgia Cancer Center reposts those tweets. So, yeah,
Okay.
because I saw different backgrounds.
Because remember, that was a suggestion made by Karen DeBro from the CDC team. So we have to circle around back to figure out how to do that on AMP. That's a Katrina question, but I'll follow up with her. But I agree. I thought there was lots of representation from other programs.
Yeah, that's good.
Yeah, no, he's really good. He's doing a lot of the same stuff that we're doing, to hear it from his perspective was, I think, helpful.
So I guess the one thing I didn't ask, and just because again it was hard for me to unmute and stuff, but how long have they had the grant?
I don't know.
Was it 2020?
It's definitely
that they got
more
it
than
also?
one cycle.
Okay, so they've had it.
Because I remember talking to somebody else from South Carolina. They've done it a couple of times, and so I'm fairly certain it's more than one cycle. I don't know if it was the same group or not, but
Yeah, it seems like his program has been fairly recently, onboarded, as opposed to University of South Carolina's program that has had several cycles of funding.
maybe what it was,
Yeah.
Yeah, and that question you asked. I'm sorry.
Go ahead.
Yeah, the question that Cheryl asked about the how do you get the population tool? Most of the states are funded for health center control networks, HCCNs. A lot of them elected to invest in providing these kind of population management tools rather than relying on the health center to go purchase them, as we've seen how expensive they are, for ECW. Georgia's health center control network decided to buy servers and do that with that money, which I think was probably a tactical blunder. But there are a number of other states that actually have Azara that they use as a population management tool. It's not the easiest to use, but as people get more experience, it comes out better. But that is a challenge we have in Georgia.
It's easier to use than having somebody come through medical records.
Yeah.
Yeah, that's true.
So just a little technical question. I noticed that at one point, Dr. Sheldon's camera kind of flipped and he's fumbling with something. Curious, Brenda, if that happens, can you shut the video off of someone or not?
Yes, I can do that, but I didn't catch that time.
Okay, because I was trying to look for you in the stream, and you might have been the TeleECHO screening project person that I was trying to say, can you shut his video off, please?
Yeah.
It's kind of like, it was an accident, and then we all have our little, Zoom accidents, but
yeah. So if I ever pick up a can of beer here instead of my cell phone, cut me off. Okay.
There's been some wild stuff, man. Wild stuff. I'm sure everybody has their stories.
I missed the first few minutes of Dr. Schlueter, however you say his name.
Yeah, I wrote it phonetically after he said.
So I missed who actually is funding his their project.
Well, it's the same as ours. It's the CDC. It's the
CDC.
same project.
Okay.
Yeah.
We heard him speak on a peer-to-peer meeting.